the various advantages and the good things about the various aspects of refractive surgery. Basically, my premise is to take you through complications of refractive surgery. Dr. Babu Rajendran, who was supposed to be the last speaker, is unable to participate because of ill health. I'll be partly covering his topic. I think all of us are familiar with the Hippocrates oath, the first do no harm, and as practicing physicians, we owe it to ourselves and patients to do that. And especially when you consider patients who present for refractive surgery, people in the prime of their productive life, for whom just a glasses or contact lenses would serve quite well, we take them up, and if we leave them behind with a disability which affects the vision for the rest of their life, far after our professional lifetime is over, that's something totally unacceptable. So essentially, statistics don't matter here, but even a single patient suffering is something which is not quite on. So there was a lot of bad press about the outcomes of LASIK. In spite of various other modalities being available, LASIK still is what's refractive surgery 90% of the times being performed. There was a meta-analysis that was commissioned by the American Society of Cataract Surgery, and I think it's a great study in the sense that Kerry Solomon identified 3,000 peer-reviewed articles since 1994. Please note the year 1994, that's almost 16 years back, when refractive surgery was in its infancy, LASIK was in its infancy, and I think we have made significant advances since then. This was based both on Ovid and PubMed databases. The key word that was used was LASIK. And it was not journals of North America, but almost the entire world that encompassed this particular study. And the result of meta-analysis showed that 95.4% of LASIK patients worldwide appear satisfied with their outcomes. That's a great statistics. And if you were to go for any elective cosmetic surgery, or I won't really call laser vision correction a cosmetic surgery, but if you have to compare it with it, something like liposuction, breast reduction, breast augmentation, etc., then this is the single most procedure which offers the greatest gratification to patients. But can we rest on our laurels and say that everything is absolutely good? Statistics is the great liar, and it depends on the way you are looking at it. This also tells us that 1 in 25 patients is not satisfied with the ultimate outcome. Is this quite acceptable? Can you tell your patients that 1 in 25 chances that you are not going to be happy after I do this procedure on you, when all he's needing is glasses or contact lenses? I'm sure many of them would walk away. So essentially, there is a significant amount of complication that is involved in any form of refractive surgery, and most often it's overstretching the procedure that leads to this problem. For a long time, refractive surgery used to be a single specialty, a single instrument specialty, in the sense it was radial keratotomy, then subsequently it was PRK, then LASIK. But today we have multiple options, as the various speakers have wonderfully initiated before me. LASIK, surface ablation, phakic intraocular lenses, refractive lens exchange, intracorneal inlays, corneal collagen cross linkage. So you have to pick and choose your patients as to customize your surgical options depending upon what exactly they need and what suits you best, what you are most comfortable with. So ultimately these patients will end up with the best of outcomes. I claim to be doing refractive surgery for almost a decade and a half, but if a -2 diopter patient walks into my hospital and says that I'm perfectly happy with a soft contact lens, is there any way you can promise me total freedom from glasses? There's no way I can assure them. That's simply because the laser delivery, the physics of lasers, irrespective of the company that you are dealing with, is reasonably good. It's well established. But what we have no control over is the corneal response that this laser ablation provokes. Basically, there is a significant difference in healing. That's exactly the reason that you get under correction, over correction. That's exactly the reason, even though you might have followed all norms, there are certain corneas which go into keratoectasia in spite of being corrected for about a -2 or a -3 diopters. There are instruments like the ocular response analyzer become available, but they seem to be quite an inadequate tool. And it's not just the quantity of vision that might be suboptimal after refractive surgery. Even more importantly, the quality of vision might significantly drop. This is the kind of glare, halos, night vision difficulty. What if the patient is inside your testing lane in an eye hospital, is able to read up to 6.6 or N6? If he or she has to drive back home, and this is the kind of vision they are going to experience, that's absolutely unacceptable. And this could happen directly proportional to the amount of myopic correction that we are inducing, especially if it's not a wavefront optimized treatment. That's because we are converting a prolate cornea into an oblate cornea, where the central cornea becomes flatter than the periphery. So if there is a drop in quality of vision like this, it's again something which is not quite acceptable. I must say that in the last decade and a half or so, significant advances have taken place in different platforms, and our understanding has also significantly enhanced. The principles of our treatments has changed, and the availability of wavefront optimized, wavefront guided, topography guided, custom Q, PTK, we are able to ensure that our patients not only get a good quality of vision but also quantity of vision. But I must confess here that it not does work every time, and there is still a significant number of patients who are not quite happy with the ultimate outcomes. There was a nice talk delivered by Dr. V.C. Mehta on wavefront aberrations. But then these wavefront aberrations, the physicists have identified right up to the 63rd order. To us clinicians, what concerns us is only up to the 4th order. The 2nd order being the myopia and myopia, hyperopia and astigmatism. The 3rd mainly the coma and the trefoil, and the 4th being the spherical aberration. These aberrations seem to be literally talking to each other. Correction of one induces the other, and we clinicians really do not understand the language that they are talking. There have been attempts at emanating algorithms so that these variables have been taken into consideration. I think there has been some progress that has been made, but then still we do not end up always getting an ideal refractive surface. I think this is one of the most dreadful complications of refractive surgery, that is leaving behind a bilateral keratoectasia in a 22-23-year-old. This is a patient I had treated in 1999, a doctor's son who became an engineer, went off to the United States. He was a 4th-year student when I treated him. At that time, I had only a topography which gave me information about the anterior surface of the cornea. I would consider that the inferior cornea is somewhat irregular, but because his corneal thickness was quite adequate, I went ahead and treated him. He was quite happy. This doctor referred quite a few patients to him. 3-4 years later, he started having complaints. 5 years later, when he came, this was the problem he had. The corneal thickness has dropped down to 339. This is the right eye, and he had a significant keratoectasia. And look at the left eye. That looks even. The corneal thickness is just 296 microns. And obviously, it was a very suboptimal outcome. We had an extreme struggle in managing this patient. There have been patients who have gone for keratoplasty because of a suboptimal outcome. I must say that our criteria for selection has become extremely rigid, and nowadays we take only such patients, and it's not just in our clinic, but world over the incidence of keratoectasia is dropping because refractive surgeons are becoming more aware of this problem, and there are several tools that are available for us to identify patients who are predisposed to this problem. For this is a OBSCAN topography which just does not give us information not only about the anterior surface but also about the posterior surface, the curvature map. This is the Pentacam, which again is an excellent tool. We have access to both these instruments, and also algorithms like the Bellin-Ambrosio data is emerging, which is giving us even better data about identifying patients who are predisposed to keratoectasia and not taking them up for surgery. I think understanding of corneal biomechanics will be the ultimate challenge as far as laser vision correction surgeons are concerned. I think this field is still in its infancy. I did mention that we have this ocular response analyzer, but we find that the results from this instrument is not always predictable or reliable. And if we are able to identify eyes which are more deformable than others and not just simply go by the corneal thickness, obviously we might be able to avoid these complications to a greater extent. We have been using the microkeratome 99% of the times. It works very well. Maybe you can even say 99.5% of the times. But then occasionally you end up with the best of instrumentation, you end up with a problem like that, a buttonhole. This is just one of a whole library of complications that I have. Good news is that you just don't we understand the principles, we don't do anything, wait for 3 months, go ahead and do a recut, create a flap, go ahead and treat this patient, and the refractive outcome is quite all all right, though the central corneal opacity that is there obviously has an impact on the quality of vision. Does this mean that now we have this excellent tool of femtosecond laser and this problem is going to totally go away with? There is a definite learning curve attached to this particular instrument also, and I'm just showing you one of the varied complications that we had. I must say that this was in the initial phase, and this is the suction loss even before we reach the visual axis. Of course, we know the ways to deal with it. We just switch off the pocket, reapply the suction ring, and go ahead with the treatment and create a fairly adequate flap and complete the treatment. There have been instances when we have created an inadequate flap and we had to use a scissors to cut the flap edges. There have been instances when we had to abandon the treatment and go back again a month later and do this. You can see the way it's being handled. Don't worry about the subconjunctival hemorrhages. It doesn't bother the patient. It doesn't bother me. They will go away. But what we are concerned about what's happening on the cornea, it's femtosecond laser is definitely a significant advancement over the metallic microkeratomes, but it's not as if it's completely bereft of problems or it solves all our problems. These are two eyes of the same patient, a 21-year-old, who after an intralace treatment for a -3 diopter spherical error developed bilateral DLK. This is a 90 micron flap and an extremely thin flap in the center, and this is me doing a interface wash almost 4 days after the primary procedure. The vision had dropped down to 660. It is doable. There are methods of managing this, but mind you, the central corneal thickness of the flap is just about 50-60 microns because there is a certain amount of thinning that has taken place also. So we do we know that it will not completely disappear over time, and we have managed it. I mean, you can see that in a month's time, the central cornea is quite clear. The mud crack is gone. That was the right eye picture. This is the left eye picture. But would the patient have accepted that this is the kind of trauma that he or she has to undergo before they get an optimal outcome? There was an excellent presentation about surface ablation. What if we break the limits? For us, the limits of -6 diopters of myopia. Excessive ablation, -10 diopters perhaps without the use of mitomycin C, causes a dense reticular haze like this. Obviously, leave alone quality of vision, this is going to create a considerable drop in the quantity of vision. Phakic IOLs, I'm all for it. I started in 2004 with iris clip lenses, but this is the kind of corneal edema sometimes that might come with it because of progressive endothelial cell loss, and we have almost completely given up these iris clip lenses because of its anterior chamber location. There is also these lenses, even after minor trauma, can sometimes get disinclavated. Mind you, I am a very, very serious refractive surgeon. I intend pursuing it very intensely, and I am no way trying to dissuade any one of you from taking up this wonderful specialty. But like any other branch of medicine, this does have a certain set of complications that come with it. And since especially we are dealing with patients who are otherwise quite comfortable, we need to be completely aware of them. What about ICLs? We have almost completely shifted over to implantable contact lenses. And just now, Dr. Bharti gave an eloquent speech as to how these lenses work. But cataract was a major concern because of the proximity of these lenses to the natural lens. And because of the wall that is there inherent in these lenses with the version 4 lenses that we are currently using, this kind of cataractous opacification is somewhat less. In more than 750 implants that we have done, this is the only case of significant cataract that we got. And even then, even this is quite limited and not progressive, so we are just observing this patient. There was, of course, another patient who developed a cataract, but that was after a subsequent detachment surgery which was done after a year and a half of the ICL treatment. I think it was more the silicone oil which was put in, which was responsible for the cataract rather than the primary surgical procedure itself. Collagen cross-linkage. Keratoconus, we are most concerned about it, and if you do collagen cross-linkage, it works very well. We do at least half a dozen of them every week. But then, and it's so easy to do. You just your technicians can do it, and it's fairly pays you reasonably well. The investment is small. But then you have to have extremely strict criteria, selection criteria. These are some of our own patients, some of the corneas after collagen cross-linkage. But all these cases resolved. I had a significant discussion with Dr. Theo Seiler, who was basically the person behind this entire concept. Many of these patients are immunocompromised patients who have rheumatoid arthritis, less corneal thickness, insignificant, and in these cases, if you put them on significant amount of steroids over a period of 3 to 6 months, they all almost completely resolved. Sometimes a reticular haze is left behind. They might have a best corrected visual acuity of 6:9, 6:12. Of course, the primary condition of keratoconus itself can cause a problem. But then you have to be aware this kind of horrendous pictures can evolve after a simple procedure like a corneal collagen cross-linkage. So, friends, I think as I already mentioned, refractive surgery is a great specialty, and I think all the various speakers who preceded me have given you an excellent overview of what is all possible in the current day. But at the same time, it comes with a word of caution in the sense that there are several complications that might accompany them, and the challenge for the modern day refractive surgeon is to do effective and safe surgery so that every individual who presents to his clinic completely benefits from it. Thank you so much for your kind attention.